Okay, today we've been submitted a case. This is a recent attendee to our Ultimate 3D workshop, and this is the first case submitted by this person. As we can see here, this patient is missing tooth number 23 through 26, the lower anterior front four teeth. As always, I always start with what type of surgical guide is appropriate here. And we would go down the digital workflow, whereas we can utilize a CEREC data or an impression to manufacture either an OptiGuide, DigiGuide, or a CEREC guide. Since this is multiple units, I would take CEREC guide out of the question. That would leave me OptiGuide or DigiGuide. And then in this particular case, I would choose an OptiGuide because it is the guide that comes with a certificate of accuracy. And when I'm doing multiple implants and trying to get everything exactly where I need it to be, I feel that an extra $100 or so is totally worth having a surgical guide with a certificate of accuracy. So the good news is we can bring CEREC data in here, and as this person has already done, they have brought the CEREC data in, as you can see here, and they went ahead and designed a 4-unit bridge for us, and they look like they designed that in bridge mode as properly planned. I do want to take a look at our CEREC design here so I can give a few minor critiques to what's going on here. Generally speaking, this looks designed extremely well. Here we can see that our emergence profile is probably going to leave some black triangles. That's good for the patient to see so that you can communicate that. Our incisal edge position looks very nice. My only critique with this particular design is that we did not design linguals properly. I'm pretty sure that our teeth aren't going to be that thin, and as we look at it from the lingual, my guess would be that the proper location on the lingual for our margins would probably be somewhere like so. So when drawing our margin, I would have probably drawn them more like that, like so that we can get a better idea. Now, not that big of a deal. We'll be able to still design and plan and all of that, but again, I just like to be able to see so I can know how lingual I'm going to be, how it's going to come out of the tooth, am I going to be able to do screw retained. All these different things are some of the things that I would be looking at in terms of whether or not that's the ideal design. So let's go ahead and take a look at our implant plans. These are the plans submitted by the dentist in this particular case. And just to kind of show you here, this is what I'm talking about. From right here, it looks like our implants are quite a bit lingual, but we don't really have any way of truly knowing that without really, the benefit of having true sizing in terms of our teeth there. So I would encourage us to next time or even this time go back to our CEREC machine, redesign, or just do some position rotate scale tool on this bridge. You can do that in group mode and kind of do all 4 of them at one time to get a better idea of the tooth width to see if we're going to be quite a bit lingual there, because in that case then we'll have our emergence would be almost a ridge lap out to the front of those restorations. So the other thing that I want to keep in mind when I'm planning a case like this, and I've done several like this, is that I would like to make these implants parallel. And the reason I would like to make these implants parallel is that gives me the ability to do engaging abutment screw retained. So if I can get the implants parallel or within a few degrees, 5 degrees of parallel, the possibility of doing a engaging screw retained is pretty good. Worst case scenario, if I'm within 5 to 10 degrees, I could probably do a non-engaging abutments and do a screw retained restoration that way. And then also if we can get the placement to allow for the access to come through. Just to re-emphasize, again, I don't mean to beat a dead horse here, but to re-emphasize, can't be the thickness of those restorations. They've got to be at least, I can't imagine that the cingulum is not, at least that thick to a certain degree. So thank you on that. So let's kind of move along here. So let's go ahead and start here with this implant. And one of the things I'm looking at here is when I look at this, I want to evaluate, is my implant correct? And one of the first things that I see when I use this 360 degree is I'm going to see that our incisal edges on the upper teeth are kind of at an angle there. So what I would like to do is see that come back to a straight line with my implant. So what I'm going to do here is I'm probably going to go ahead and rotate this implant a little bit like this. And now we can see how it looks like I'm straight up and down to my adjacent teeth there. Now, to go ahead and try to get a better position here, I'm going to assume that my cingulum is going to come out about like so. So now I can see right here that I'm right lingual to the incisal edge, like that, and that's going to allow me to have a screw retained restoration and yet be a little bit more in line with the final restoration, okay, and not have a big bulky ridge lap here. And when I do narrow diameter implants, if I have the ability, I'd like to go to the 13 millimeter implants. I think this one is going to be pretty straightforward in that sense, right there. So I like this as a good starting point for my implant placement. And then what I'm going to do on number 26 is I'll go over here to the change implant button, and then I'm going to go ahead and make this parallel to 23. And now what I'm seeing is that at least right now I am parallel. Okay, so that means I could do a screw retained restoration right now as I have it, but I just need to now work on the bone position. And there, what we're going to see on this one, unfortunately we see oftentimes in lower anteriors, is that this particular case is going to need some grafting. Now, whether you're comfortable doing that grafting at the time of surgery is a personal decision, or do pre-grafting in this situation, or maybe do some ridge expansion using some osteotomes along with immediate placement, placement at the time of expansion, and then some grafting as well there. Different techniques depending on each person's comfort level. Also on this particular one, we can see that we're quite close to the adjacent root, so we're going to move that until we get it more ideal there, and now we're far enough away. Now what we do have to look at when I did that is that now my implant is in between in the embrasure space like so. So now we can see that my implant has come into the embrasure space of that tooth. Now honestly, there's probably not much I'm going to be able to do about that. Aesthetically, if that's a concern for the dentist, then we may have to go to more ideal placement, slightly off angle, and then use custom abutments with a cemented bridge. But I would personally take this type of minor compromise to have a screw retained restoration. One, because I do firmly believe that screw retained restorations are better, and then from a financial lens, certainly they're better for me and the patient both. So what I'm going to do here is I'm going to try to minimize that effect there and go ahead and bring that over a hair more like so. And there we go. And then since I made 26 different, I'll go back to 23 and I'll make that parallel to 26, and there we go. So I think this is a totally doable case. 23 should be relatively straightforward. We again maybe some undersizing, maybe some use of some type of expanding drill, and then number 26 is definitively going to need some grafting here on the buccal, and that's a personal decision in terms of how we'd like to do that and when we'd like to do that. The last thing is to go ahead and add in our surgical sleeves here, and here we can see we have Hyosin guide in there, and their particular sleeves are this size, and just to make sure that those sleeves fit and everything looks good. So based on the data we're provided, as long as we can manage and be comfortable with that grafting on site number 26, I think we're good to go on this particular case. I would definitely order a fully guided system so that this implant doesn't have a tendency to push out to the buccal, and go from there. So thank you very much for submitting this case. I hope you found that helpful.